and then we will switch to Brugge to Peter Uvin. Peter, can you already hear us?
Hello?
Yes.
Yes, hello. Well. Hello, Mark. I can hear you. Do you hear me?
Perfect.
All right, perfect. And you have the endoscopic view now, or maybe the view of the room? I don't know.
We have the view of the room. We see
the view of the room.
Yeah.
Perfect. Well, that allows me to thank the team. That's wonderful, wonderful nurses, Debbie and Stan, who actually gave up their holiday to come here.
We want to see
Kevin,
the nurses.
who's taking care of the ICT. They don't want to be in the image, I'm sorry.
Looks like you're there all alone.
Also here. Yeah. Well, actually, I'm very used to doing this surgery completely on my own, actually. So normally I don't have a table nurse or a nurse next to me. Sometimes a resident, of course, but that's more for teaching than for my comfort. Okay, so and I also want to thank the patient actually for giving his consent to stream this surgery. So it's a trilobe of prostate of around 60 grams in a man of 60 years old. So I introduced the instrument already. And if you allow me, I would start with the procedure.
Can we see the endoscopic view?
So, now, if you can switch to the endoscopic view, please. Okay. All right. So now, Marie, you should be able to see it.
We can.
All right. Perfect. So I'm actually in the prostate. I haven't started the procedure, of course, yet, but I've introduced the instrument. And as you see here, the first thing that I'm doing, that is looking for the border of the mucosa on the sphincter, which is around here, and the mucosa on the adenoma, which should be around here. So we will start by making an incision right at this edge, and then we will try to bring this incision up.
As you've done over 1,000 of these cases, I bet for you it's very easy to identify where the mucosa is identified on the apex. But can you help us with some landmarks?
Yeah, well, first, of course, I start on the verumontanum for a big repair, but it's not the definitive repair, for sure not. In bigger prostates, it comes behind the verumontanum, as you see here. And actually, I'm looking a little bit on this edge here. As you see here, this looks like the mucosa on the sphincter. And here you can actually see that it turns out that here is the adenoma. So I'm actually really looking at this edge. I don't really have another way of putting it than that you really have to find the edge between both mucosal planes.
Can you tell us about the energy settings that you're using, and are they different for the apex and for the rest of your procedure?
No, I don't use any different settings for. I don't switch the settings during the procedure at all. I always use the same enucleation setting, which is 2 joules and 50 hertz virtual basket setting. So that's the pedal that I mainly use, because I think that's a setting that really allows me to give a lot of power to do the procedure, hopefully in a nice anatomical way. That's at least the goal. So as you see here, I'm trying to get around the sphincter. So here is now I'm in the sphincter, as you see here, and I'm developing the white line, as of course it's called by Professor Sancha. Because I have quite some mobility here, I try to deepen it out already just a little bit. So I will just cut right here at the edge. So sometimes you do not have access here. So that's the thing about the enucleation, of course. If you don't have access where you want to go, you just stop and you go to another place to create this access. In the more easy prostates, you have access. Look for it, of course. And if you don't have the access that you want, then you try to find another place and you work your way until you have the mobility. It's all about creating mobility in the adenoma. It's all about, creating the space for yourself for the instrument. And of course, the whole point of this procedure is to show a MiLEP procedure, which is of course a more slim instrument, which is and one of the advantage, but of course that's something for the discussion later in the afternoon. That is that, sometimes you just feel that you have a little bit more access to the places where you want to go, because an instrument that is a little bit more slim, it's not illogical, of course, that you have more mobility with this instrument. So what I'm trying to do here is to develop the posterior plane As you can see here, it's quite thin on the posterior side, but that's not a bad thing necessarily. So I'm just trying to be as complete as possible and try to develop the posterior plane, of course, in the direction of the bladder neck. So
we already had your mentor here before for the first procedure who told us that prostates are onions and we have different layers. How do you identify which layer you will choose? Because we know that there's definitely a lot of different layers. Do you go for one layer or do you go for the ideal layer? What's your opinion?
Yeah, the problem is that the ideal layer is not always there. I'm trying to find here the ideal layer, but I don't find it. So then I have to just use the layer that I'm capable of finding. So there's not always an ideal layer. I think the most important thing that is that you have one layer, and that you are trying to connect all that you don't end up with a lot of different layers and a lot of different incisions, so that you just try to connect everything. I would say it's more my goal to connect all the layers than to find the ideal one, especially because there's not always an ideal layer. Actually, I stopped doing TRP completely, except for maybe the very rare situation after brachytherapy, but for the rest, I don't ever do a TRP anymore. So I do it also in smaller prostates, and for sure, you don't always have a perfect layer. Okay, that's convenient. So this is actually the bladder. It's quite surprising for me that I'm already here at the bladder. I don't have that a lot. It has to do with the smooth shape of the prostate from the posterior side. So normally I cannot manage to get, without forcing the instrument, which I never want to do, to get to the bladder. Now I see that I'm here at the bladder. So that's a good thing, because it makes life easy for the rest of the procedure. But I have a very important thing that I want to mention, and it's good that I see it here, because now maybe you could say, oh yes, I'm at the bladder, because I'm sure this is bladder. It's black is bladder. It's not a perforation, it's bladder. But I do not want to open it, because if you open it here, the prostate will pull anteriorly. And then the rest of the procedure to circle around the prostate would be more difficult. So what I wanted to say that is that normally posteriorly you don't get immediately to the bladder if you develop the posterior plane. Here I do, but don't open it completely. There are two reasons. First one, you don't know where the orifices are at this moment. And the second reason is that your prostate, if you open it, pulls up anteriorly, and then the rest becomes more difficult. So that's something that I've learned by doing it the first time. And hopefully you don't make the same mistake by hearing it me say.
So Peter, you mentioned the instrument being smaller than classic enucleation instruments. Do you believe there will be an advantage on urethral stricture rate?
That's a very, very, very good question. Actually, I do, but there's no data yet. So I come back to that in a couple of hours. So I will. I think it's only logical. You're using a smaller instrument to do exactly the same job. So in my opinion, I think that it will lower the urethral stricture rate. But I mean, this is just an opinion. So there is no data that proves anything. There is some data about urinary incontinence. I will show them in a couple of hours, because that's of course something that is much easier to quantify. You can just ask your patients postoperatively, did you have any urinary loss? And a lot of them after the whole will say yes. In the beginning, although it's maybe not a tragedy, but a bit of urinary loss, it happens. And that's easy to quantify. And that's there are statistical significant differences in the rate of urinary incontinence comparing Charriere 22 whole MiLEP with a classical Charriere 26. I will show it in a couple of hours. Then about the stricture risk, there is no data yet, but my feeling, if that has any value, that is yes.
We're looking forward to these data.
Yeah, well, there is no data, of course, but what is very clear, that is that if you introduce a Charriere 22 instrument, you have to force less than sometimes with a Charriere 27.
So Peter.
All right, so this is.
the image
Yes.
quality right now with your smaller scope is still great, which means that even though you have 4 French less of a scope, your irrigation is still great. And I've used the MiLEP as well, and I think your irrigation is quite nice, maybe even better than a 26. But one of the downsides of this equipment is the morcellator scope that you will need to use at the end of the procedure. So I'm wondering, do you use this equipment in all of your patients, or do you choose your patients based on a cystoscopy beforehand, evaluating the urethra? How do you choose to do a MiLEP procedure or a regular equipment procedure?
Yes, very good question. I will come back to that in a couple of hours as well. The answer is that I tend to change completely now to MiLEP. There's for me no reason anymore to do classical whole lab, but sometimes the reason is that my sets are gone, because I do it in 2 hospitals. I have 4 sets in St. Lucas. I have 3 sets now in St. Jan. So sometimes when I plan a lot of whole labs, then I don't have a lot of sets. So that would be the only reason, actually. There is one exception, and that is if you want to do a combined procedure. For example, for a patient who also needs a bladder biopsy or something, or a patient who also needs a double J stent, yeah, well, then you need to have a complete instrument switch. But the size on itself, of course, in the beginning it was different, but the size on itself, for me, is no reason anymore to change my strategy. Of course, what you mentioned about the morcellation is very true. We will see that in a moment, although they are creating a chip on the tip endoscope, so hopefully in the future that issue will be resolved. But your comment is very, very valuable, but it's still possible to do a safe job. I've done around 250 MiLEPs by now, and I have one morcellator issue with only mucosal damage. So, I mean, it is really possible to do the job safely, so there's no problem there. But I agree. It's also a personal thing, of course. Of course, I did not change immediately. In the beginning, I did only MiLEP procedures which I did with prostates until 50, 60 grams or something. And then gradually that changed. And the thing is also, if I would run into problems with my MiLEP during morcellation, because indeed the visualization is less, I hope I will be able to show that to you, and if I proceed well, to also show the morcellation. But if the visualization is less, I can always switch to my other normal whole lab morcescope. So this gives me the confidence to start with the morcellation with the MiLEP. And if I run into any problem, I can just switch. So that's a bit the strategy that I'm currently using. Now in St. Jan, so right now I'm working in St. Lucas. In St. Jan, I actually only have MiLEP instruments, so I'm not even able to switch there because I never started the classical whole lab program there. So there I got on MiLEP because I'm convinced it's better, but okay, let's wait for data, I agree. But I don't have a classical MiLEP there in St. Jan, so I have to say that there I tend to program patients only until 120 grams because I cannot switch to classical morcellation if that would go wrong. You know what I mean? But the enucleation, I mean, you see, there's no problem. I mean, if the visualization is good, the flow is good, I think it's even the enucleation part during MiLEP, I think it's even more easy than with whole lab because the instrument is much more mobile inside the urethra. So the enucleation will not be a problem.
So Peter, this is Carl. Very nice job.
Hey, Carl. Thank you.
I noticed that you use a special kind of camera. So this is not a angular camera, but I've seen it was a kind of laparoscopic camera. Can you comment on that? So why are you using that? What are the advantages? What's the cost of that? And so on.
It's a very, very good question. That's true. I use a straight camera. Maybe I don't know if you can see it during the in the overview image. Kevin, maybe you can show maybe just a second the overview that people can see what Carl is talking about. Just
Can we
like
focus on his hands for a second? See the room, but...
Would that work?
Of course, it's a camera.
I don't know.
Well, we see that you have a straight camera on the end of your scope instead of a pendular camera.
Yeah, well, okay, so maybe I could just tell that, of course, but it's it's you can switch to the endoscopic view.
See both,
please. Thank you. Yeah, well, so the thing is that during MiLEP, you need a little bit of digital zoom. In the beginning, when I was using a pendular camera, you needed a bit of digital zoom. So I needed to put it on 1.2. And then the story, because it's actually a quite funny story, especially because I know that Thomas and Carol are listening. So after the BEAM Congress, which you guys organized so nicely, I put a little video of myself wearing the BEAM hat, doing a whole procedure with a pendular camera with a digital zoom of 1.2, and I put it on X just because I liked the hat so much that you gave to us. So I thought, okay. And then Felipe Figueiredo, which is the inventor of MiLEP, he saw the video and he said, "Peter, you're doing it all wrong." So he sent me a message on WhatsApp and he said, "Oh, please, you're losing image quality because you're using the digital zoom." And that's true, of course. It's a little bit like zooming in when you're having an iPhone. So you lose image quality. And he told me that I should switch. So, of course, I listened to Felipe Figueiredo, and then I switched and I asked the people from Olympus, what should I do? Because I needed a straight camera, because the thing is, with a straight camera, you have an optical zoom. I will show you. So you see, I can just zoom in and zoom out. See? It's a bit, I don't know if you see the image changing, but
yes,
anyway.
You do.
Okay, well, so you can zoom optically a little bit like a photographer who has like this very expensive cameras with a lens, and that allows you to zoom in without losing quality, which is an advantage with MiLEP. So that's the story behind it. And then the thing is that Olympus looked at what I should use to do that, and the funny thing was that those cameras were just here. They were just being used for laparoscopic surgeries by my colleagues from abdominal surgery, and I could just use them. And the advantage is that they use them sterile. They have 8 of them. So I can use a sterile camera, which is nice because I don't need this camera draping. I mean, it's not a problem, of course, to use a camera draping, but it's it costs 30 euros. Okay, sterilization
Switching out to the next scope goes a lot faster.
Yeah, well, and it's just nice, Okay, so actually the adenoma is, I think, almost enucleated, so that's good. So now it's completely loose. I will come back to the sphincter area. You see, so that's the goal of the en bloc approach that I'm using. That is to keep the sphincter area here intact. You see, so here's the edge of the sphincter here is being cut without that it's being teared open. So that's the whole idea of the en bloc approach, which we are currently using. So I really like the sphincter. So I have the feeling that this patient will be immediately continent, at least I think that, and I hope that. Okay, so now we have to finish the enucleation. So this is like the baleen sign, or the whale sign. It looks a bit like the mouth of a whale. So we open here and we go inside the bladder.
We see that your laser is on top of your screen now. Do you think that's an important aspect of when you open the bladder neck, that you have the laser at the 12 o'clock position? Because it looks very nice.
Yeah, I think here you want to be as high as possible. You know, you want to open the bladder neck as high as possible. You want to open the bladder neck completely, increase or decrease the risk of bladder neck sclerosis and open it up completely. So that's what I want to do. This is the median lobe, as you see. It's a little bilobar. Yeah, okay. So that's what I want to do. To open it up completely, of course, it makes sense more to put the laser fiber at 12 o'clock. Also, I'm not really turning my instrument like this. I prefer to keep it at 12 o'clock because that allows me to work where I really want to work without forcing. I really that's a bit the whole idea or philosophy from my surgery. I try to limit the amount of forcing that I have. I don't want to damage urethra, and I don't want to damage the sphincter. So I think if you turn, maybe you do it a little bit more. I don't know. At least this works for me.
Peter, we see quite a median lobe there. Did you identify the orifices in advance?
Yeah, in the beginning, well, that's a very good question also, because in the beginning I did. So I tried to go inside the bladder, and that went fine, and they were quite far away. But if I have to force again, that's the whole thing, then I do not enter with my instruments. So I do not enter with my instruments when I need to force. So in 1 out of 3 patients, I start the enucleation without forcing, without doing a cystoscopy. So I don't mind about doing that. And I just go inside the prostate. I feel that there's too much resistance to get in the blood. The orifice is here, so they're actually nice far away. That's good. And then I start the procedure immediately at the apex without forcing, because if I force the instrument in, again, I don't want to damage the sphincter, but for an en-bloc approach, that's extra bad, because you want to identify the sphincter. And of course, if you have a lot of bleeding there by forcing, then that makes it even more difficult. Here you see I have a little bit of adenoma left, so I will try to take it with me. I love PSAs of 0.4 after the procedure. So let's try to do that. Of course, you have to find a balance here. Right here, you see there's a little bit of fat that you see in the background. It's not a real perforation, of course, but I call it more the bed of the median lobe, and then it always is a little bit thin here in the back. Okay, so let's develop it like here. So maybe for people who have watched videos of Fernando Gomez Sancha a lot, which I can only advise you to do because they're wonderful. This is something that I do different, because he's like a godlike enucleator, and for me it's a little bit different. When I have opened the bladder here at 12 o'clock like this, I go until 10, until 2, and then I put my fiber at 6 o'clock. I have a look at the orifice, and then I work my way around the adenoma down. And that's something that he does different. He just keeps his fiber at 12 o'clock and enucleates it completely. But I feel a little bit more safe like this. Here, of course, the orifices are far, so I cannot really damage them, or I should be, or I should be doing something very bad. But
we see that you're nicely at the bladder neck, and the prostate is almost dislocating itself inside of the bladder. Sometimes with the larger prostates, we see that the prostatic tissue is undermining the bladder quite a bit and going behind the bladder. How do you manage those? How do you prevent perforating there?
Yeah, very good question. First thing that I do, if I feel that I have to push here, which I don't want to do, first thing that I do is I cut the anterior commissure here. See, there's very little tissue here. So here it's really I will do it. I don't think it's really necessary here, but there's nothing to lose with that. So if you cut the anterior commissure here, then it opens up a little bit more, and it becomes more like a horseshoe, which already allows the prostate to get moved a little bit more in. You see, already I gained some even here. I don't think it was really necessary, but I think that it creates some access for the prostate to be located inside the bladder. So that's the first thing you can do. And then I really try to find my way here. I try to do like a V shape. So I made my incision here, and I come here like this, and I do the same on the other side. So, and I create this kind of V shape, and then the only place where the adenoma is attached is at the tip of the V. So that's what I want, and then I try to very gently, again, no pushing, but lifting the tissue. And then I try to work my way around it. And if the orifices are very close, so here, they're far away, but sometimes they're like here, and then I just try to make this mucosal incision I always want it medial from the orifice. So that's for me something that because this is actually a phase that the residents can do. Actually, I have to say that I always start my procedure itself, unless for very experienced last year residents or fellows. But from the moment that the sphincter is completely released from the apex, then actually it is possible to give away the instrument to your residents in a safe manner. So that's something that I really have to teach, that they come here and they medialize the mucosal incision from the medialize the mucosal incision medial from the orifice. Okay, so that looks good. I think the adenoma is almost enucleated. Okay, so that's good. So now it's inside the bladder. So here is the orifice. It's far away. It's nice. And now we will do a combination of hemostasis and maybe just a little bit of cleanup here. I mean, of course, this is not really.
And you do that with the laser, or do you ever still switch to the loop?
Yeah, very good question. Well, the first years that I did in enucleation, I always did it with. I ended the procedure with an electrical loop. So I used to do like 2 hemostatic phases. So I did the phase now with the laser, because I think for arterial bleeders, it's better with the laser. And then I switched, I did my morcellation, and then I did an electrical coagulation with a bipolar reusable loop, which is available as well for the Olympus system that I used for classical whole lab. As for the MiLEP, there's also like a roller ball that you can use, and it's reusable. It's not expensive. But a couple of months ago, we got the Magneto, the Quanta Magneto system, which is really nice for hemostasis. So actually, I'm using that now. So it's the right pedal, which I'm using now. It's a wonderful tool for hemostasis. So you see, it's like a long pulse. It's good to dust stones, but I don't do that. You do, of course. But it's also good for hemostasis. This long pulse is really gentle pulse, and it's really, it's really nice. Okay, so this looks good. So here is the verumontanum, of course. And as you see here, this prostate is not super big, of course, but as you see here, this the adenoma extends well distally from the verumontanum. And I think it's very important that if you want to enucleate, that you respect this. You cannot just try to go here and then think that you will do a good job, because first of all, you won't be anatomical. You will leave in the apex, which is, and in a lot of cases, the problem with patients who have complaints after TRP. So for functional reasons, you shouldn't do it, because if I do a redo after TRP, most of the times there was done a good job here, but here there's still like an apical donut hanging around, which I have to enucleate. So for functional reasons, it's not good. But also, if you want to enucleate, you want to follow the anatomy. And if the anatomy says that you have to go here, then you have to go there, especially in large prostates.
Some enucleators would say that going through the adenoma at the apex to prevent from harming the sphincter or urethra too much is fair. What's your opinion?
I disagree. I think it's not fair, because fair, of course, you can do it, but I'm not saying that you cannot do it, but you will be less efficient, because you work your way through the adenoma here, and you will be and you will leave some tissue here that you do not need, because this patient will not be incontinent. Look at the sphincter here; it's very nicely preserved. He will be good tomorrow, I think. So, and I have to say, this is nice. Of course, I did not choose the most difficult case, but sometimes it doesn't look like this. So I cannot say that it always looks like this, but this is my goal, to have it like this.
That's very, very nice.
And then he will be continent, and so then you do not need to leave here an apical donut. All right.
We have 2 more minutes for you to show us the more.
I'm sorry. Oh yeah. Oh yes. Okay. Yeah, you should see it, because. I will have to change. I'm sorry. Okay.
Which morcellator are you using?
Piranha from Wolf. I'm using. I'm sorry.
You look so lonely. We're all with you.
Thank you. So I use a second inflow for the morcellation. The laser, of course, should be on standby.
So you've switched out.
So
you've switched out the camera before you take out the other camera that's inside.
Yes, I prepared the instrument completely, and then.
Because you want to prevent the bladder from emptying and decreasing the pressure.
Yes, yes, indeed. So I switched everything, and then I just installed the morcescope completely, and then. And then we are ready to start the morcellation. So you see, of course, I mean, this image quality is not great, but this is a thing that only has to be done safe. I mean, you don't need a lot of precision here. You need to be able to do it safe, and that's it. So I will just check that everything is all right. Okay.
Any tips on having a more efficient enucleation based on the settings, aspiration, so on?
The aspiration?
The morcellation. So what's the oscillation speed?
I'm sorry. I used 975. Yeah, 975. I have a couple of pedals. The first one is around 975. The second one is 600. So that's what I'm using. It tends to depend a little bit on the tissue quality. It tends to depend. Of course, on the size of the adenoma, and if you use reusable blades, which I do for financial reasons, of course, then it also depends on the times that have been used already. I think, it's good that you see this morcellation because, of course, the image quality, it's not ideal,
but it's still
enough
nice
to do the job. Yeah, it's enough to do the job safely, and also this improved because of this tip from Felipe that I got because of you guys. Thanks. So I guess this is going fine.
Just happy we could help.
Thank you.
Peter,
yes.
It's Jolstra here from Zolder. Nice procedure. Congratulations.
Thank you.
I would like to ask you something about the MiLEP. Of course, during the morcellation phase, that's what Peter Scotterman learned to me, that you have to see what you're doing. So with the MiLEP, of course, you've got, because of the lesser size of your instrument, you've got sometimes less irrigation. So what do you advise to the colleagues who are in education for the whole lab to use the MiLEP here? Because that...
Yeah, to be honest, I don't think that... If you're supervised, you can do MiLEP morcellation. But if you want to start on yourself, clearly I love MiLEP, but I don't think it's the ideal first set. I think first you should get a classical set, but buy 1 or 2 and not 4 or 5, because afterwards you can go for MiLEP, because you should be able to switch to a classical MiLEP morcescope if you are not comfortable at this stage. I don't think that in the beginning it's ideal. But yeah, the vision is reduced, but Filippo told me that you shouldn't see Brad Pitt to do the morcellation nice. His point was like, you don't have to have a good vision, you need to have a safe vision.
I think an important aspect is that the hemostasis has to be virtually perfect.
Yeah, it's true. Yeah, it's true.
This looks very, very nice, and it looks like we're almost done, as are we with this session. Thank you very much for a beautiful procedure. It's very nicely demonstrated. Also the enucleation. Looks like you'll be done in a few minutes, and then you can come over here, enjoy a coffee, and tell us all about MiLEP on your talk later on today.
Thank you.
Applause from the audience.
Thank you, Peter.
Thank you.
I think we can close off this session. We had 3 beautiful demonstrations of different techniques to approached the same organ. We had a pulsed thulium laser enucleation of the prostate. On bloc, we had a green light laser vaporization of a gland, and now we have the holmium-YAG enucleation with a slightly different technique at the apex, and we see that we all get quite nice results of the prostate. I think whichever way you do it, try and be as anatomic as possible and create a nice open prostatic fossa. And the goal, of course, is to have the patient home as soon as possible without too many complaints and a low risk of strictures. I think the MiLEP may play a role there. The data is yet to be demonstrated, but all in all, thank you all to the three surgeons for this morning's session, and we'll see you all later. Thank you.